So next we'll introduce Dr. Eldad Elnekave, coming to us from Israel. He's an interventional radiologist, and he will describe his system of DEE. If you look at what that means, it's arterial, doxorubicin, eluting, embolization as a desmoid tumor treatment.
Thanks. It's good to be back here. Again, it really does get bigger and more people every year. It's fantastic. Okay, I'm going to start this with the way the actual procedure began, which was in a multidisciplinary form, and you know, this is what this is here is really a multidisciplinary form where you have medical oncologists, surgical oncologists, and interventional radiologists, sometimes radiation oncologists, discussing a case. And it's very important because generally, you know, we have an expression in Hebrew that if you have a hammer, and, you know, everything looks like a nail. And when you're together speaking about a case, people will have different approaches. So I'll start with let's see. Just trying to move it forward. Okay. So I'll start with this. So we saw this patient in a multidisciplinary board back in 2014, and she had 4 surgical resections of this right axillary desmoid tumor, and had multiple different chemotherapy lines, and you know, and she had responded to some extent to doxorubicin. And so, you know, we thought, great, well, give her more doxorubicin. And the oncologist said, we can't. This is, you know, the amount of doxorubicin she's going to need. Doxorubicin will work for this tumor, but it will also really destroy her heart. So we can't give her that, you know, we can't give her doxorubicin anymore. Which goes back to, you know, the point that Alex spoke about earlier, which is that, you know, these patients, desmoid patients will suffer because of the disease and the treatment that they get. And you really want to be as kind of gentle as you can. But in a case like this, we have to be as aggressive as possible because, as we can see, I mean, the tumor is really bringing in the chest wall. And so now, which leads me to this other point. If I still don't need to do this, there you go. All right. Is that we're talking now about an approach which is local and systemic. So we've heard about different systemic therapies, and we've heard about local therapies. So cryoablation being one of them, HIFU, for example, being a local approach, which is not systemic, meaning it's not the whole body. Different systemic approaches, different chemotherapies, tyrosine kinase inhibitors, gamma secretase inhibitors. But what about the local delivery of a systemic drug? And in this respect, you know, how can we turn doxorubicin, which is effective, into a local therapy? And the drug will help us because this drug in particular tends to bind. It is attracted to a negatively charged coating, to a sulfate coating of a small bead. And that bead is small enough that it's much bigger than a blood cell, so it's not going to fly through a tumor, but it's small enough that it'll get stuck deep in a tumor if you can get it to that tumor. This is what it looks like. So you've got doxorubicin, that ruby, and doxorubicin is the red, and you have microbeads, which are negatively charged kind of coating. Drop them in, and then the drug is attracted to the coating, and then the beads actually recruit or hold on to the drug. And then, so you have some help on the part of the drug in that the drug will bind to a small particle, and you have some help on the part of the tumor because the tumor itself will also create new blood vessels. It will recruit blood vessels from adjacent normal arteries into it because it needs to grow. It needs more blood. So if you're an interventional radiologist and you like to catheterize blood vessels, you can navigate into the tumor. So we'll see here, what you can see here is the arm of the patient and the tumor and the chest wall, and the navigation of a microcatheter really deep into where the tumor is, and the delivery of, again, a systemic effective therapy, doxorubicin, but without the systemic toxicity because the drug is given locally. So after 4 treatments, in 1 year, we had we had a really good result of about 97% of volume reduction, and that color that we see in around her the region is the color of the drug. So there was no further therapy apart from 4 treatments and a total of about 200 milligrams that she received. This is in 2014, and it's been stable since. Another example here of a 16-year-old with a forearm desmoid. And this also speaks to what you see, that little mushroom there is actually a response to a biopsy that he had there. And this is a guy who had prior surgery, had prior systemic therapies as well. And here again, if we can navigate a catheter into the intraosseous artery, the forearm, we can really see that we can target that blush of the tumor without any risk of getting any injury to the hand itself. And then 9 months later, in 2 treatments, we had a good result. And this again has been stable since. This was back in 2016. So we first published on our four patients in our first experience, for this kind of called it a promising approach for a perplexing disease in 2018, and then planned a prospective trial. But meanwhile, I was so excited about this, I was yapping about it to all my friends in different places. So we had a prospective trial in our institution, but we recruited all the data from friends who were doing it at Memorial Sloan Kettering or at LMU, in Sydney, in Hong Kong, and we ended up creating sort of a combined prospective, retrospective study data. I'll tell you a bit about that. In this, I'll show you another case. We were treating tumors that were not just in kids and not just extra-abdominal, but this is an adult patient with a mesenteric tumor. What you can see here is really the whole abdominal wall. So almost the entire mesenteric space is occupied by this tumor. You can see the pelvic symphysis below and the diaphragm above. And what you need to do is catheterize, in this case, the superior mesenteric artery, the vessels that are supplying the bowel, and also and localize the supply to the tumor. And again, here, 2 treatments and 9 months later, I'll show you what this looks like. So we do this under cone beam CT guidance. So we catheterize the tumor feeding vessel, and then make sure that we're in the blood vessel of the tumor without blood supply to vital organs around it. So what we can see here on the left is that diagnostic CT. These are axial images, so you're kind of looking from the feet up, and you can see that kind of very, very bright star-like structure on the right here, which is actually the catheter itself. And then the white in general is contrast material, and you'll appreciate the mass that looks like an oval space. And in the middle image, you'll see contrast white material above and below it, which is the material within the bowel that is in the abdominal wall, in the mesentery. And that's from the injection from the general mesenteric artery. And once we have a catheter in the tumor itself and we inject contrast, now we don't see any of that white material or that contrast in any of the bowel. At this point, we're safe to deliver the drug. So the results here, in 10 months later, and again, this was 2 treatments, was really good. We see both the reduction in size of the tumor and what you'd expect to see, which is a decrease in what we call the T2 intensity, the how white the tumor looks in CT, in T2 weighted MRI imaging. So I'll give a little bit of data on the 24 patients that we treated and reported on just in December of 22. So 24 patients were treated, and about 62% were women. the majority of tumors were in the abdominal wall or in the extremity, so 25% in the extremity and 29% in the chest wall, abdominal wall. We had 7 patients, or 30% of them, with neck, shoulder, axilla tumors. And we had 3 patients with intramesenteric tumors and one girl with a mediastinal tumor. That was just a tumor that was behind her heart, that had basically obliterated the esophagus and was beginning to compress the trachea. Most of them had prior treatments, so a third had prior surgery, 2/3 had some systemic therapy, so 24% this was first-line treatment. And the median time from diagnosis to treatment was about 2.5 years. And the median number of sessions, of DE sessions, was 2. And generally we gave those sessions 2 to 3 months apart. Total doxorubicin dose is about 49 milligrams and per session, with a total of about 75 in general. So our image-based responses. So for all patients, you'll hear the term RECIST a lot. It's what's increasingly, and increasingly we're using metrics that are appropriate for Desmoid, which is what is the volume of the tumor that's being decreased. But we'll talk about tumor progression or stable disease or partial response. These are the numbers. They are. So briefly, if we look at all responses, partial response was 39%, stable disease 52%, and 9% patients have progressive disease for all patients. You'll notice that we're talking about 23 patients and we treated 24. That's because one of them didn't have follow-up because of a complication. There was a neurovascular complication in catheterizing a vessel that was near the spinal cord. So he had a spinal stroke, which actually recovered pretty well from, but we didn't have regular follow-up from him because we didn't complete the treatment. So we're looking at 23 patients. There's a difference between, so the majority of patients had follow-up of less than 6 months, less than 12 months, because the pace of accrual, number of patients we were seeing really kind of was accelerated. We had 7 patients with, we can see here a median follow-up of almost 3 years, and for the other patients, a median follow-up of 5 months. So the first 4 patients, it took a year to recruit every patient. So 4 years for 4 patients, and the next year was about 4 patients in 1 year, and we're at the point now where we'll treat a patient a week. So if we did a study right now retrospectively, most of our patients would be very short-term follow-up, and then we'd have a small cohort with long-term results. But there is a difference between those 2 results, regardless of how many treatments they received. So if we look at the patients with long-term follow-up of over a year, the 71% have a partial response, 2 have stable disease, none have progressive disease, versus 25% of those with a follow-up interval of less than a year had a partial response, 63% stable disease, and progressive disease of 13%. Volume-wise, those with a longer follow-up, we have a 76% median reduction in volume, compared to 44% volume reduction in those with under a year of follow-up. So this is our waterfall plot in RECIST terms, and this is what it looks like in terms of volume. Let's look back and see safety. Again, we had one significant complication, we call grade 3-4 complications, and everything else was something that didn't really require any significant management. So pain after procedure can be significant, and it really varies. In general, patients will have significant pain for the first night or 2 days, and then pain for the next week. We generally don't require more than NSAIDs for the first week, although for the first day or 2 days, I'm comfortable giving whatever is necessary. And generally, we keep patients overnight for the first night. See here. I just want to talk about the experience from Memorial Sloan Kettering. So these were 11 women treated. All of them had tumors in the abdominal wall. Very similar results. There's a short-term follow-up. So the average volume reduction was 18% at 1 month and 38% at a median follow-up of 5 months. I'm still looking forward to the longer-term data here. At 1 month, 6 patients had improved maximum pain, while 3 patients had worse pain, but at the last follow-up, 10 patients of the 11 had improved pain, so 90%. So that's all, what we've done sort of until now, and just a word about what to do going forward. So the challenge here is the challenge and the advantage is you have a procedure which is it's not exactly, the treatment is not categorical in the sense that if you're getting treated, you don't receive 40 milligrams of something twice a day. The question of how to treat the tumor, what dose to give, how aggressive to be, this is really going to vary from patient to patient and from treatment to treatment. And so there are 2 things that are required to make this kind of similar, by the way, to a procedure like HIFU, and somewhat similar to cryoablation. It's operator dependent, and the treatment is there's a lot of gradations. So the plan is to conduct a larger phase 2 study, which is prospective, in 5 institutions, 4 different countries, between 20 to 30 patients. And make sure that it includes medical oncologists, interventional radiologists, and surgeons that are involved, so that we have input. And again, we started off with a multidisciplinary conference and discussion, and we want to end up with a multidisciplinary kind of perspective and view, a recommendation on how to utilize this technique so that it's easier to adopt and use everywhere. And I'll end with that. Any questions? Do you find you have better results with a dark, dormant portion of the tumor or the enhanced, more active portion? So actually, if the tumor is dark on T2, I won't treat it. I think that is a great question. It's really important. Part of the inclusion criteria for this study is that you have to have T2 intensity in that tumor.
Can you talk about the availability?
So, thank you. So availability. I think the key here, I speak with a lot of interventionalists in different places in the States and abroad when there are questions about how to perform the technique. And generally, I'm comfortable with tumors into those 2 questions. One that I've turned into 2 questions. One is which is the appropriate patient, and then availability. So tumors that are on the extremity, chest wall, abdominal wall, I think I'm happy speaking with interventionalists. It's not too complicated. Just needs to have, you have an interventionalist who's comfortable with treating tumors. In the States, I know we have experience in New York, Memorial, and in Salt Lake City. I'm sure there are others that I'm less aware of. Again, it's a challenge. The challenge is to increase availability and awareness of the procedure. Let me see what we got here. Is this approach being used or investigated in other solid cancerous tumors? Yes. How does this treatment impact the cumulative doxorubicin dose? Okay, so we have some pharmacokinetic data that we haven't published, but in general, we're talking about a systemic portion of less than 5%. So it's almost trivial, the amount of doxorubicin that a person is receiving as a result of this treatment. Is this being used in other? Yeah, we're investigating it in other sarcomas as well. I'll be speaking about that in a couple months at a different conference. But it's a useful approach for other sarcomas as well.
Go ahead and ask. You want to?
My question is about how many times can you treat the same tumor?
How many times? Depends on the size. So generally I haven't had to treat the same, artery multiple times, but but I've treated, I think up to five times for a single patient. Mostly it's 2 to 3 times, but actually this woman with a mesenteric tumor, that was 2 treatments, and it was just 1 feeding vessel that was, giving. But for tumors that are, say, in the axilla, can have multiple different feeders, and generally 2, 3, 4, if it's a large tumor, is common.
Are these patients followed with echocardiograms? Have you found that there's any cardiac side effects?
So the question is about echocardiograms and the concern of cardiotoxicity associated with doxorubicin. Formally, we do a cardiac echo before we treat, but again, because the dose of doxorubicin is so low systemically, I don't think there's a particular risk.
So you're saying you don't do this if there's not T2 intensity. Are there other, whether it's location or small size, are there other tumors that this works less for, or?
So there's a risk consideration. So things in the mesentery. Okay, let's talk about forgiveness of the adjacent tissue. If you have a tumor in the gluteal muscle and you take out part of the gluteal muscle because you have non-target embolization, it's okay. But that's not the case if it's on the neck by the carotid with any risk going to the brain. Similar if it's in the mesentery or the mediastinum. It doesn't mean that you can't do it. It just means that it really requires a lot of planning and it's higher risk. So again, extremity, chest wall, abdominal wall, I'm very comfortable.
Unrelated to that, what about a tumor that's wrapped around the brachial plexus or involved in the spine?
Spine I haven't done. I don't. I haven't. No, too risky. Wrapped around the brachial plexus. Here's our advantage here. The advantage is that you can give a small dose and see. We know that the doxorubicin is going to irritate the nerve, and we can try to hydrodissect, where it's possible. But if there's no other good option, and sometimes there isn't, then I have done sort of a dose escalation in the same patient. So started off, I did that with the girl with a mesenteric tumor. She had 3 treatments. The first one was 7 milligrams, and then 20, and then 60. Sure.
Move the rest break.